So we have so many residents and students who are attending this meeting, and I really wanted to take this opportunity to welcome them from us. Thank you for coming. We're so pleased you could join us, and happy that you could attend the colloquium. And we hope that the students and residents take advantage of the opportunity to network with the incredible folks that we have attending today. So lastly, before we begin, I wanted to talk about the format for this morning's session. So Dr. Finkelstein will be our first speaker, and he'll be followed by Dr. Jennifer Below. What I'm going to ask you to do today is to use Slido to post your questions. So after Dr. Finkelstein and then Dr. Below speak, we'll have a panel up here, a panel discussion, where your questions that are in Slido will be presented to them for their response. So we're not going to have individual question and answer sessions after each of the first two speakers this morning. But please feel free to type your questions into Slido. They will not appear on the screen. During the presentations, we'll have those. We'll collate those. And our moderator, Dr. Francis Kim, will then present them, and we'll moderate that discussion session. So we're going to do something a little differently this morning. So thank you very much for your patience with us as we move forward with this. The first presenter this morning is Dr. Joseph Finkelstein. Dr. Finkelstein is the director of the Center for Bioinformatics and Data Analytics at Columbia University College of Dental Medicine. Dr. Finkelstein completed his PhD in biomedical cytometrics, followed by a postdoctoral fellowship in biomedical informatics, both at Columbia University. Dr. Finkelstein researches patient-centered health information technologies, supporting precision medicine and personalized care. He is a recognized scholar with several awards from NIH, the Agency for Healthcare Research and Quality, the Department of Defense, and several foundations as well. The Center for Bioinformatics and Data Analytics, led by Dr. Finkelstein, develops, evaluates, and implements innovative technologies supporting the delivery of personalized dental care in the context of the healthcare system. Dr. Finkelstein's presentation is titled Using Big Data to Promote Precision Health in the Context of Learning Health Systems. So please join me in welcoming Dr. Joseph Finkelstein to the podium. Dr. Finkelstein.
Hello, everyone. It's a great pleasure to be here. Thank you so much for inviting me. As just was mentioned, my primary area of expertise is biomedical informatics. So I really enjoyed presentations yesterday and was very excited to learn about the dimensions of precision medicine in oral health and oral public health. As I was listening yesterday to wonderful presentations, the number of slides which I can present without duplication was rapidly decreasing. So I had to adjust a little bit my presentation. I'm a faculty at Columbia University, and at Columbia University we were the early adopters of precision medicine. Precision medicine is one of the primary items at the mission at Columbia University Medical Center, and correspondingly at College of Dental Medicine at Columbia University, we strive to employ precision medicine into dental care delivery. In September this year, our Dean Stoller, opened a new Center for Precision Dental Medicine, which specifically is focused on employing big data and data analytics to promote precision dental care delivery. So during my presentation, I will focus on three major items which served as an impetus for us to move on with precision dental medicine concept. There are many other considerations, but for the purposes of this presentation, I will focus on three major challenges which are actively discussed in literature and dental care delivery. So first challenge is lack of up-to-date evidence-based guidelines. It's not that there's no guidelines and there's no evidence, but the pace in which evidence is updated and implemented is very slow. The second challenge is limited integrative analytical data sets. So in order to facilitate implementation of evidence-based guidelines, we need to have knowledge discovery which can be facilitated by integrative heterogeneous data sets. And also once we have strong evidence, we need to learn how to implement it quickly and efficiently. So what I learned from yesterday, that there is a very significant synergy between approaches in precision medicine and oral public health, because all these three challenges are prominent both in medicine, in dentistry, and oral public health. And I can state that at least the approaches which we employ, which are listed at this slide as a solution, are equally applicable in precision medicine and oral public health. So one of the ways to address lack of evidence is to employ knowledge discovery pipelines, which yesterday was mentioned, based on big data and health analytics. And I will discuss how we can approach this. And I think it's equally attributable both in precision medicine and public health. But in order to do this, in order to implement this powerful and effective and significant knowledge discovery pipelines, we need to have verified and integrative data sets. And to do that, the current trend is to employ intelligent integrative informatics approaches. I will discuss them more in detail, but briefly, the solutions are integrative because they utilize multiple heterogeneous data sets from basic science, from electronic medical records, from patients, from environment, and etc. But it's not sufficient just to merge these silos in one enormous data set without understanding what these data are and how they are interrelated. This is why intelligent is the first kind of characterization here. Intelligent, that means that these data sets know about themselves. They include metadata, which describes what is embedded in this data and how this data interrelated. So by implementing intelligent integrative solutions, the underlying systems which utilize these intelligent integrative approaches would understand on computer language, on the level of modeling, what's the interrelationship between this data, and then they can facilitate knowledge discovery in more optimal way. And finally, once we discover this evidence, how do we implement it? And one of the ways to facilitate implementation is to utilize the concept of learning health systems, and I will discuss it a little bit more in detail later. So overall, the agenda which is shared between precision medicine and precision oral public health is to be able to constantly update evidence-based guidelines and to utilize verified and actionable data sources, utilize effective implementation tools, and employ proactive stakeholder engagement, which includes wide community and representative from patients to providers to policy stakeholders and etc. And learning health systems may be one of the vehicles which can address it on community levels. So my first claim was that we need more evidence. So there's an ongoing call for evidence-based oral health. It was widely promulgated in social media. Here's an op-ed from New York Times, where, as I mentioned, there's a surprisingly little evidence for the accepted wisdoms about teeth, and they were talking about evidence about certain preventative measures in oral health. But in scientific literature also, we are familiar with different calls to enhance our knowledge and update the evidence for preventative procedures and other procedures. And for example, this article, which is presented here in the bottom, states that the research evidence is not of sufficient quality to reach any conclusions regarding the beneficial and adverse effects of routine scaling and polishing for periodontal health and regarding the effects of providing this intervention at different time intervals. So what it means that it doesn't mean, I don't read it as scaling or cleaning is not efficient, but maybe there are subgroups of patients who need it more and need it less. And preventive personalized precision care should help us identify what are the priority population where it's helpful and what are priority population who may not be the primary target of this. So following these discussions, National Institute of Dental and Craniofacial Research came up with a comprehensive plan how to implement data science systematically, and they actually have standing RFAs for research, and they came up with a wonderful article which kind of describes importance of this subject for dental care delivery and dental public health. Interestingly, our dean, Dr. Stoller, was a long-term proponent of precision medicine, and particularly in pain medicine, but also in other areas. When I researched literature in preparation to this presentation, I was pleased to find out that dental professionals were actually in forefront of big data and personalized medicine. So I want to dovetail Dr. Slavkin and give tribute to dental professionals, not only in leadership in genome discoveries, but also in big data analytics. So this is an example of a treatise published in 1757, where dentist professional describes an amazing cure for toothache, and the analysis was done based on thousands of patients, as it's claimed. So for this, for 18th century, it's a really big data. And also what is proposed is actually a very interesting personalized solution where a letter which specific perfume, which is tailored to particular subject, is provided to patients. Patients are convinced if they carry it in a pocket, then their toothache will go away. I think it's a really a creative way to do big data and provide personalized medicine. And actually, there's a lot of credibility into this because I see it as an approach to utilize placebo. And actually, we know that in many patients, placebo can be as effective as powerful pain medications. And if we are able to identify such patients, potentially we could avoid prescribing powerful opioid medication to patients. And but the question is how to identify them. So with current tools, we can employ precision medicine and identify such patients. So another examples which I want to discuss with you, which is kind of probably more relevant to this audience, is fluoridation. So we all know that based on series of epidemiological studies in 30s, it was demonstrated that the caries prevention benefits from naturally occurring fluoride. And the first community water fluoridation took place in Grand Rapids in 1945. And it was shown that the presence of fluoride prevents the net loss of tooth minerals and decreases the rate at which episodes of demineral occur. And here's a graph which shows that a significant proportion of US population is now enjoying this very powerful preventative strategy. However, implementation of this preventative approach was not without obstacles. Here's a poster which was promulgated in 1955 by Society Keep America Safe, which stated that fluoride is red poison, which was introduced by communistic world government to weaken army campuses. And 60 years later, another social media outlet claimed that Putin bans fluoride in Russia, which actually is banned there, and because it's a toxic poison. So what this underscores is that we constantly need to update our evidence and also monitor social media, and for public health professionals, utilizing social media and outlets is crucial to maintain public health. And actually, if we look at scientific literature, recent systematic review done in Harvard University found that child's intelligence scores were inversely associated with high exposure to fluoride. Another article found that hip fracture prevalence was positively associated with high prevalence to fluoride, though this particular article was later critiqued by a systematic review. However, one can ask question why babies needs fluoride before 3 months, years of old if they don't have teeth, or why edentulous older adults need fluoride. So the question is how we can use analytics and data science to develop strategies which potentially can channel the population-based strategies to particular subpopulations in optimal way. So this is very interesting graph which was presented by World Health Organization, which compares two kinds of countries. In Europe, most of the countries forbade fluoride, and this graph compares two types of countries and how the trends of tooth decays over a significant amount of years. And we can see that all countries enjoyed very significant decrease in tooth decay, both countries which has a significant fluoridation program and countries which do not. So it kind of brings us to this idea of a classification models in precision health. So in the traditional model it's a population-based model where we use cross-sectional design studies or longitudinal design studies, and based on odd ratios, hazard ratios which we identify, we draw a very broad conclusion and then apply this conclusion to vast, enormous populations. The emerging model is to focus this conclusion on particular cohorts and relevant measures. We talked yesterday about socioeconomic status, haplotypes, it's a combination of different SNPs, enterotypes, exposome, or many other parameters where we can focus and then deliver medical intervention, dental intervention, or public health intervention to subgroups of population which particularly benefit on this, and it's maybe more cost effective. And finally, the future model is N of 1, where we would be able to find the best interventions for particular person with particular constellation of socioeconomic status, haplotypes, enterotypes, exposomes, and all other parameters. And I would not object that even public health professionals would employ this if technology and cost effectiveness allow. So, but to employ these very ambitious models, we need to have a precision health. We need to have a lot of data streams and big data. And there's multiple data sets right now available, and there's ongoing work how to integrate these data sets in effective knowledge discovery pipelines. So I like this representation of big data and how these different data streams are aggregated. I like it because the patient is in the middle, or human being in the middle is in the middle of this slide. On the x-axis, we see this variety of data streams which can be generated from genome to metabolome, microbiome, environment, and patient's disease conditions. On y-axis, we see multiple outcomes, which is a result of these different effects on the patient. But in the middle is a person, and the person is wearing multiple devices, if any, which generate multiple data. It may be wearable, it may be other, it may be smart home, which generates multiple data, or many other. It may be car, it may be credit card. It's multiple data are generated by patients. So another layer are peer and interactions. It's social media, it's social persona, and etc. And the third is interaction with providers, including public health professionals. So I think that this slide represents very well where data are coming for precision public health. So in dentistry is extremely saturated by different data streams. Of course, first it's electronic dental record, but also there's a variety of other appliances which are used routinely in dental care delivery, which generate enormous number of data, which can be potentially very helpful in contributing to this overall exposome. The second layer of data, which was very widely discussed yesterday. I'm not going to speak a lot of this, but it's different omics data streams. Another dimension is what we call mobile health, but there's emerging mobile oral health, and I think it will only grow. So first of all, there are more and more devices which actually objectively measure how toothbrushing habits and can actually document it. This data can be stored, analyzed, and in the cloud, but also it can use to provide immediate feedback to patients, to children, or to adults, to kind of guide them how to employ better toothbrushing habits, and gives them employ certain what we call behavioral informatic methodologies, where they get certain behavioral models are employed, where like behavioral economics and etc., where subjects are also awarded for their correct behavior, and they are guided on day-by-day basis in being adherent to best preventative approaches. So the level of creativity is endless here. So, for example, there's another application which is used by adults, and certain adults are concerned, for example, about brightness of their teeth, so they can actually make daily picture or weekly picture and monitor the level of the brightness and interact with their professionals and improve their care. For those who actually are not compliant, cannot be adherent, there's an automated toothbrush actually, which will employ all the best toothbrushing practices automatically. And also there's a new model which can individually deliver fluoride varnish on particular tooth, and also certain antiseptics, and even also brush the tongue. So there's a variety of approaches in dental or oral mobile health which generate enormous data, which also can be useful for preventative intervention. And the next layer of data streams is social media, which allows us both to learn about important oral public health issues, but also to effectively intervene. So I like this article. The first is Discovering Foodborne Illness in Online Restaurant Reviews. It basically was done in collaboration with Columbia University and the Department of Public Health. And it's actually actively working model where they download daily Yelp reviews by guests of different restaurants, and they analyze it using machine learning, and they were able to train their model to identify places where more than one or at least one credible complaint is, which is congruent with potential foodborne illness, and they actually can proactively intervene. So I think it's a very exciting way to use media for public health. Interesting article from Japan where they found that the level of edentulism in older adults was correlated with number of social connections. So we all know about the negative impact of social isolation in older adults, which affects not only on kind of mood and depression, but also on total health. It turns out that it also correlated with oral health. And at Columbia, we have an older mobile program, which is run through our oral public health program, which is led by Professor Barton Edelstein. And we know how important it is to implement a targeted intervention to promote oral health in older adults. An interesting article about account of bullying on Twitter in relation to dentofacial features. So again, this article shows us kind of insight from social media about factors which affect these particular patients, but also it gives us vast opportunity for tailored intervention, both on this particular on victims and promulgators. So, and overall, it's already well known that social marketing is a very powerful strategy to affect large populations, to promote population health messages, and it also shown that it can be very useful in reducing oral health inequalities. Example of this, of social marketing in oral health is the Mighty Health Mighty Mouse program, which was implemented recently to change knowledge, attitudes, and behavior. And social marketing programs, they're all rooted in very careful review of big data, which allows to analyze the main drivers of particular attitudes and behaviors, and then develop uniquely tailored programs. So overall, if to summarize, we can identify at least 4 major data streams. One is data streams which are emanating from patients, including wearable devices, social media, monitors, and self-report. The second are clinical data, electronic dental record, billing, pathology, and other data which generated as a part of routine care delivery. And I include here also provider characteristics, which are also important. Next is the biological data, and we discussed them in depth yesterday. But another very, very important area of important digital information are what I call normative data sets, which should be also accounted. And it's data from clinical trials where data were very, very carefully collected. It's also data from nationwide observational studies, from Framingham to Enhance to Enhance and many other very carefully collected cohorts, which can provide us gold standards and distributions which are very precise. So together, all this data combined can facilitate continuous knowledge discovery, which would promote personalized care, optimal wellness, patient-centered care, individualized decision support, and targeted therapies. So, but how do we combine all these data sets coming from very different sources, from very different institutions? It was mentioned yesterday, there's 4 major electronic dental records. There's multiple electronic medical records. Fortunately, we have Observational Health Data Sciences and Informatics Consortium. It's also led from Columbia. Its architect is Patrick Ryan. And this is a consortium, it's an international consortium of multiple institutions which actually came up with, I would say, a common denominator. It's a relational model of care delivery which allows to map any electronic record to a common data format. So it doesn't matter how you store your data. Once it's mapped to this common data format, it can be then merged together in one database, or it can be analyzed as a part of federated database on the same terms. And this is how this common data model looks like. It's basically a set of representations of different dimensions of care delivery from patients to provider, but also it has standardized metadata. So it has over 100 medical ontologies or vocabularies which cross-reference different ontologies or different vocabularies so that we can go from electronic dental record, which is in Korea, to electronic dental record, which is in Columbia University, and merge them together, and Apple would be apples and origins. And all this data would be comparable and used in a universal, verified manner. At Columbia University, as I mentioned, we recently implemented Center for Precision Dental Medicine, which is a brainchild of our dean, Dr. Stoller. And it's exciting initiative which potentially can revolutionize dental care delivery, but also may have implications for oral public health. So, and it employs this another notion or set of data streams which we call dental Internet of Things. It's basically a floor which was specifically designed, which has it's a 16,000 square feet floor with 2 wings, which has a very innovative 48 dental chairs specifically modified for this dental Internet of Things. Why this chair was modified? It was modified to provide a complete and a very detailed account about what's happening during dental care encounter. So you see this chair. So, and first it provides a wide-angle camera for viewing and recording overall operator environment. Second, it provides patient biometric support for logging stress, pain, and etc., and other physiological responses. Third, it actually tracks whether patient is present and no, and it allows positively ID both patient and providers, so we know exactly who did this encounter and to whom. It has also Lighthead integrated close-angle camera where actual dental encounter in oral cavity can be recorded for educational and if necessary, IRB-approved purposes. It also provides millisecond logging of tethered handpiece utilization. So all these handpieces which are used during dental care visit, they are tethered with this chair, which is driven by computer actually, unlike standard chairs which are pneumatically driven. Inside this chair there's a computer which drives all this and logs the parameters and all events which are used during dental care delivery. Altogether, this, what we call all this Internet of Things and all this logging is aggregated in one database. In addition, this environment allows also to track patients, providers, instruments, and materials. So all patients get attack, and we using sophisticated systems, we know all their trajectory from waiting room to dental chair, and we know their wait time. We know if they wait too long in the waiting room, and etc. The same about providers, and most importantly about instruments and materials. So, for example, from public health perspective, it allows us to ensure that all instruments which are used underwent timely autoclaving, and whether it meets the rigorous standards of infectious control. And we can monitor use of all these devices and actually understand what the implications are for dental care delivery. So objectives of this undertaking is first to implement comprehensive digital infrastructure for research and development in dental health, develop decision support tools for digital dental office which are evidence-based, support big data analytics, implement decision support for RFID-based dental tracking system, build central data repository, incubate important new digital technologies, and provide a very fruitful environment for our faculty. So there's the two major challenges we need to address. It's obvious. First is data aggregation. So how we aggregate this data so that it's become this intelligent, integrative environment which I mentioned before, and how we normalize them using different semantic ontologies. And the second is data analytics, how to avoid this effect of garbage in and garbage out, how to actually develop a really impactful result from this enormous amount of data. So this diagram shows kind of another representation of this data, and it includes patient tracking data streams, asset tracking data streams, and also different data streams which are generated during routine dental care delivery. So to summarize, this data include RFIDs, chairs, supply cabinets, medical images, EDR, and videos, and potentially they can have impact on clinical management, or cost of care, quality and safety, efficient utilization, teaching, and total health. So in order to take advantage of all these exciting opportunities, we need to build predictive model which will identify optimal procedures, predict oral health outcomes, stratify risk groups, classify systemic diseases, provide deep phenotyping of dental conditions, allow us to identify disease trajectory analysis, allow to promote workflow optimization, quality improvement, and enhance dental education process. So this is an example of knowledge discovery pipeline, one of the many which can be implemented. So first of all, we need to avoid garbage in, garbage out phenomena, and especially with so many data, and acknowledging known limitations, let's say, of electronic dental record or any medical record, which is basically a tool to document encounter, not to do research. Therefore, the procedures may be miscoded or undercoded. The diagnostic codes may not be present at all or may be incorrect. So the first step is to implement so-called electronic phenotyping. And electronic phenotyping is very prominent in big data research in electronic health records. It basically, the notion is very simple, is that each disease or each procedure has electronic signature. Doesn't matter what is coded. Let's say if somebody has alveolar osteitis, for example, or dry socket, it means that the patient should first have extraction. After extraction, patient should return during certain number of days and complain of extreme pain. And after that, maybe return again or immediately be prescribed pain medication, etc. So even if dry socket is not coded, we have electronic signature of this event, of this side effect. So electronic phenotyping is an approach in data science, which identifies very specific electronic signatures of conditions and adverse event and procedures, which, regardless of what is stated with high sensitivity and specificity, identifies the certain classes. And it's crucial for us because basically we identify phenotypes. And using these, we can build much more precise predictive models. And after we are able to identify our target outcomes with sufficient specificity and sensitivity, we can build more powerful visualization, we can employ sequential pattern mining and build predictive models. So overall, we hope that this approach would promote continuous knowledge discovery and quality improvement cycle, where we capture data passively or actively, we organize data, we analyze outcomes, we learn from new cases, and we constantly update our workflow. And overall, this environment would promote precision oral health, allow us to build powerful predictive models, will hopefully improve dental care delivery, allow us to better employ different translational projects, which also identify underlying pathophysiological determinants of oral health. And also this environment is very conducive to patient engagement, where potentially we can use this data to identify patients' preference and the learning moments where patients can be delivered tailored messaging. This environment can promote continuous oral health delivery, where before the visit, patients are engaged in continuous preventative measures based on their individual pattern. During the clinic, using this powerful environment, the decision support is provided based on decision support based on algorithms which were implemented, and also based on analytics which can find patients like me and understand which procedures or which approaches were most effective for this particular group of patients like me, and then suggested just at the point of delivery, and post-visit, where patients constantly can be updated about their preventative care or post-visit care. So overall, we expect the impact in 4 major domains: clinical domain, where multiple research opportunities exist to study precision dental care; social behavioral domain, where we can identify health risk factors specific to particular population; basic science domain, where we would employ a variety of different data streams to also include patient genetic traits. And also, surprisingly, but for me, but actually it was obvious for those people who put it together, it actually has a very interesting impact on educational domain, particularly on student training. Using this data, we already were able to identify attendance pattern of students who would be less successful in their scholarly activities. So our center is located in the neighborhood which populated by Hispanic population, and part of our work is to address health disparities. We know that more than half of Hispanics ages 64 and older will suffer from untreated tooth decay, more likely to experience delay in care and unmet dental need, and etc. So we worked together with a representative from Hispanic community to identify how this rich data infrastructure also can promote oral health in minority communities and be used to reduce inequalities. We know that there's many different factors which affect oral health disparities, and the structure which can be very conducive to implementing the big data and precision analytics to reduce oral health disparities and to utilize this advanced decision support, maybe learning health system, which is very congruent to this notion which I described. Why? Because it promotes this very continuous cycle of care improvement to address gaps in care. And the goal of a learning health system is to deliver the best care every time and to learn and improve with each care experience. And a learning health system advances quality and improves patient safety and satisfaction. I think the best description of benefits of learning health system was given by Dr. Friedman, who chairs actually Department of Learning Health Sciences. And these are 5 major points which kind of frequently repeated, but I think they're worth to repeat again. First of all, every patient characteristic and experience are available for study. Second, best practice knowledge is immediately available to support decisions. Improvement is continuous through ongoing study. It happens routinely, economically, and almost visibly, and all of this part of the culture. So in order to implement a learning healthcare system, together with precision medicine, implementation science is crucial, and it was mentioned yesterday. So all together, precision medicine, learning health system, and implementation science can promote population oral health and precision oral health and take advantage of this wonderful, rich data environment which we are able to enjoy today. And a final point is that in order to implement these amazing and exciting opportunities, it's very important to establish leadership of dental professionals in precision health. So in our school in Columbia College of Dental Medicine, we have a very comprehensive set of efforts to employ data science in routine, not only in routine care delivery, but also in our education process. We established a very comprehensive infrastructure to promote data science training for dental professionals on a variety of levels. So first of all, we implemented an elective in data science from predoctoral students, and it's a totally web-based online course which we call DDS Squared, Digest in Data Science for Doctors of Dental Surgery. And it allows, in very understandable and clear terms, to engage dental professionals in common vocabulary and common definitions of data science, so they are equipped to work together with professional data scientists to formulate challenging problems and to identify the best practices. Nobody but dental professionals can best identify how should dental care delivery and public dental health addressed. The techniques which are provided by data science can be relatively easily become available to dental care professionals who are trained. This is why we also employed summer research experience in data science project, which actually enjoyed really great uptake by our first and second year students, and certain for some more busy, but they also involved. We have a research assistantship in data science, and we established informatics infrastructure to support faculty research in data science. So in conclusion, precision dental medicine will translate heterogeneous big data into valuable healthcare information to improve quality, lower costs, and facilitate precision health. It will create evidence to support optimal dental care delivery and will promote creative thinking, innovation among dental care professionals. Thank you.